Oh, we're stuck. What's going on? Oh, okay. So disclosures, to the exchange, and then also we have some funding from Lenovo. So, okay. Design challenge for you guys. You know that I love design, right? So tell me, what do you notice about these doors? See, I'm like testing you early in the morning.
Pull when the door says push.
Yes.
Yeah.
Right.
And the pull is no
Exactly. How the heck are you supposed to do that? Right? So do you know what kind of doors these are called? Does anyone know? Bad.
Not of the fire code.
Yeah. So it's actually called a Norman door. So Don Norman is considered to be like the father of human-centered design. He's like a cognitive psychologist by training. He wrote this really great book on the design of everyday things, right? And his whole sort of there's like actually like a lot of on social media if you hashtag Norman Door. Like his point is that the design of the artifact should instruct you on how you will use the artifact, right? So if you see a handle, it should be a pull, and you shouldn't need a sign to help you figure out how to use it, right? And same goes for this, right? This should be a push, and this should be a pull, right? But there's like a ton of Norman doors wherever we go, so my kids are always like, oh my gosh, Mom, Norman door, did you see that? So I post a lot of these on Instagram. So in any case, but I think that, so his whole philosophy is essentially like if it needs a sign, it's really bad design, right? It's a workaround. And I don't know if you guys are familiar with the EpiPen, right? My kids have food allergies and it's called an EpiPen, right? So you take the cap off and then the needle, like when you think about a pen, right? When you take the cap off, you'd expect the needle to be right under the cap. But in fact, for the EpiPen, it's totally opposite. You take the needle off, or you take the cap off, and then the needle's down here. So there's actually a ton of individuals who basically self-inject themselves with Epi instead of injecting the person who's actually having the allergic reaction. And it's even happened to like, I've even heard that it happened to like Phil Pizzo, who used to be the dean of Stanford medical school, right? So like it's bad design, right? And so look, they put a sign there. So Milan, I don't like them for many reasons because they charge way too much for EpiPen, but they put a sign here, right, which said needle end, right? And so that theoretically is supposed to help the user figure out how to use this pen. But I think fundamentally the point that I'm trying to make is like it wasn't really designed well. So despite that sign, people inject themselves all the time anyway. Okay. And so like if you when you're a healthcare stakeholder, you kind of just get used to whatever the culture is because you grew up in it, right? But then when you kind of like look through the world, right, with the eyes of a designer, like you see things in a whole new way, right? And so like I don't know if you've ever walked down an aside, right? Have you seen these signs? They're ridiculous, right? But clearly people are popping those doors out all the time and they're jamming like people as they're walking down, right? So they have to put this up here to warn people. And so, I mean, it's fascinating. I don't know if you've ever walked around that hospital, but there's like these signs everywhere because they put all these door openers in all these random places, so you can never tell which door it's supposed to pertain to. So you'll see like in the hallways, you'll see green arrows everywhere. They're like these green sticky arrows that they've literally like just permanently left on because people don't know if this opens that door or that door, right? And then this is hilarious. I saw this in the cardiology ward, and I just thought that was really interesting because I think this is a sign of a larger problem, right? I don't think this sign really fixes the problem that's happening here, right? So I'm gonna like translate this to sort of healthcare, learning healthcare, our role as child health researchers, right? Like, how do we learn from the population at large that we have here in our system, right? And I think, this would be kind of the universal sentiment of most people in the Department of Pediatrics and perhaps across Michigan medicine, although I haven't done, a random sample, right? But, I don't know who my patients are. I don't know how they're doing. I can't tell if anything I do makes a difference in their health. And I'm so tired of like being ignored for 6 months, right? Getting no response back and then being told that you can't help me, right? So I think, there's definitely been this kind of health information revolution, right? We're all using Epic now. That's a big change, right? But I would say that we we are stuck because, as we engineered the EHR in 2012, right? Like it really functions like Microsoft Word and Pinterest instead of a true database, right? So um, we created all these templates to document the patients that we were seeing, but we were basically taking all these note templates and then just cutting and pasting them into our notes as we do our clinical delivery. And I mean, that sort of was the old way of communication, right? Like that's how you, like, clinician to clinician, I need to see what the story is in order to give the right amount of care and to give the right kind of care, right? And that, this was the old model when we were on CareWeb. It was just free text, right? And in the diabetes world, we have a ton of data, like patient questionnaires. We have all of this device data from pumps, CGMs, and all that stuff, right? And right now, it's all going in um, as a PDF in the media tab. So we tend to go there a lot during our diabetes visits when we're trying to make adjustments to insulin, right? So I mean, I think we've come a long way in adapting to use of the new technology, but I do think we've sort of been trapped in our old ways of using it and being very note-centric or document fact-centric, such that it's really hindering us as an enterprise, right? And so in my associate chair role, I've been going around and talking to all the division chiefs, and what we're essentially finding is that there's like a lot of nurses, physicians, like people not working at their capacity doing chart review to collect data about health outcomes, right? We have people doing double data entry, so they're writing their note and then they're keeping a shadow spreadsheet like in the shared drive, right? So they can keep track of like all their neurology consults or, right, all of their hematology patients, right? And then, you just have this like random sampling of spreadsheets like all over, I don't know, the box, the shared drive, someone's hard drive, I don't know, right? And this is what people believe, this is where people believe truth, right? Because they'll tell you, no, 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 we have to keep our separate consult list because that's the number. The number they gave us is not the number. That's not true. Yeah.
So are the shadows?
All of the above. Yeah. And so one might say that this is probably a missed opportunity, right? To be putting this into a system that's costs a lot of money, is being maintained, and can be used for future research, right? So I've been spending a lot of time thinking about how we redesign the system, and it really does start with data, right? And it starts with the framework of learning health systems, which I think, there's been a lot of talk about. IOM has, convened many roundtables and has many publications about this, but I think ultimately the idea is that we've always operated in silos, right? So the researchers sit on the side and they do their own thing because they have like more resources and better programmers, and the clinicians are over here, and then the improvers, they don't even know where they belong yet because there's no, sort of deep culture of quality, right? So there's just been a lot of kind of stratification, and I think that, the idea is that we want to be able to unify clinical care, quality improvement, and research, right? Because those are the same patients, has the same data. Why can't we use it for multiple purposes, right? And so that's the framework we've been using. So I'm trained as a health services researcher, but I did do like a little bit of a pivot, went to Cincinnati and did the Advanced Improvement Methods course. And I do think that part of this, well, let me keep going. I've spent a lot of time kind of playing around with Epic, and I do think that really helps better or more deeply inform research. Albeit, I think that there's drawbacks and opportunities with regard to sort of local systems for data or research, right? So in any case, what is this? I had to Google this, the sewage pipe. Yeah, so I feel like that's what I've been doing for like the last 2 years. Like I've literally been like the sanitation manager, trying to deal with like cleaning up the system. But I do think it's really important going forward for giving us more meaningful data, for letting us have sort of broader insights, for letting us to apply, whatever we're already doing in our workflows to be like of greater value to the system, right? Across our kind of tripartite mission. And like I think as a whole service researcher, I think we're I used to be like, oh my gosh, like my K was totally focused on like secondary data, right? Like it didn't even touch patients, so it was like a K08, right? Like it was clinical research, but it was all database research, right? Um, and I think, I've done my epi studies and I've done my descriptive studies, right? But I think, some of the things that I realized is that like QI and health IT, that's sort of the next gen for HSR, right? Like it's the lever that you can use to take what you learn and actually affect and change things back into the system, right? And so I think, if I'm a health services researcher moving up in the world and I'm younger, like these two pieces are an essential part of sort of the enterprise going forward, because I like it. It's just the wave of the future, and I like I mean I do all aspects. Like I work with large data and I work with, I guess, smaller data. But I think, to really have impact, it's really our opportunity to think about, sort of the next gen HSR 2.0, 3.0, whatever you want to call it, right? All right. So this has been, so I don't, do you guys know what this is? This is, I was in Toledo, Spain with my family because my husband's from Spain. This is the Museum of Torture. It is, yeah. So these are like the tools used by the Inquisition to torture their prisoners, right? And so that is what I have been doing for the last, I would say like 2 years, right? So became a physician builder, got clarity proficiency. So I want to just tell you a little bit about like this tool that everyone hates, that everyone resents, right? But I think is actually has a lot of promise for us as an enterprise, right? So we have the MyChart EHR interface, which a lot of us use for research and clinical care, right? That everything we enter in, right, dumps into Chronicles, right? And that's a database used for operational reporting. It's sort of real time as soon as you enter something, right? And that can power things like best practice alerts based on the data being entered, right? So if someone comes in with a BMI of 95th percentile, something can trigger right away, right? It allows you to do there's interesting opportunities actually for randomization within Epic, and then you can do sort of research reporting, right? And then there's like the patient portal, right? And I mean, it's got limited functionality. How many of you guys have a portal? Pretty much everyone, right? Yeah, so it's just much more convenient, right? And you can use it for scheduling and all that stuff and messaging. But I think there are some really interesting opportunities, and I think these things are kind of not well known. So current state, right? So there's something called you can actually upload data from wearables into like Apple Health or Google Fit, and like a physician could actually order that a patient report those values. And so right now they don't want everyone patient sharing this stuff because the docs don't necessarily want it, right? But you can actually kind of get this into the system if the physician requests it of the patient. And so I think there's interesting opportunities for getting some of this data into self-reported data or wearable data into the EHR for like sort of clinical workflow and opportunities for research and QI, right? And then there's also this thing called CHEAR Companion, which I'll talk about a little bit later, but I think it's a really interesting kind of mobile tool that's, again, like available. Someone has to build it, but it's available, doesn't, cost $60,000 for a programmer and a separate platform, and it can go straight into Chronicles, right? So then you have Chronicles, dumps into Clarity every night. Yeah.
I'm not even sure I can actually word.
Yeah.
So there's obviously apps that you can out of them, the questionnaire one, and stuff. Are there opportunities to upload that directly on the left side also? Or is it only like you can only interface with Apple Health and stuff now?
Yeah, no, so it would be through these mechanisms. So it's pretty, I mean, I would say it's limited. Like it's not as if, so Michigan Medicine isn't like keen on letting everyone report into their EHR from every kind of database, right? So these are pretty, I would say, restricted workflows, right? So if you had like some new brand new app that you wanted to integrate, like it's not necessarily, that's not necessarily like the state of the art or the state of the present. Yeah. All right. So then this dumps into Clarity every night. So this is a analytic database, right? And so you pull data out of here using SQL. So I spent, I don't know, like I did like 3 tests. a project, got stuck doing it over my vacation in Hawaii because the deadline was going to end and they were going to like invalidate my certification. So, but that actually has been extremely useful, right? So Clarity is sort of the health system database. It's pretty restricted because you have to have all of this training at Epic in order to finish or get access to this, right? And then what happens is that a lot of Clarity goes into HSDW, which is used for more of like the health system at large, for the billing people across the enterprise, right? And then there's a separate sort of receptacle of data called RDW, which is Research Data Warehouse, right? So this is like managed by HITS. This is managed by Dr. and Aaron Kaliba's group, right? Data Direct comes out of here, right? And one might say this is a lot of repetition, but I think that happened a long time ago, and so it is what it is in terms of, you know, efficiency of scale, right? But what's also interesting is Clarity. You can do a poll in Clarity through using SQL, right? Well, you can use spreadsheets, right? But you could have it automatically query on a regular basis, right? And it'll if you use Tableau, you can use the Michigan Medicine Tableau server. You can publish to the server, and then that becomes a really interesting opportunity because all that data that you're sort of collecting in real time can be used to sort of power dashboards that you want for measuring, you know, prevalence or process and outcomes. I have yet to develop run charts for this yet. That's sort of my next task, but I'm not there yet. But like, we've just started with some dashboards that I'll show you with regard to pediatric diabetes to be able to like act on this data in a more active and proactive way. And so I think this is an interesting opportunity because this becomes automated. It refreshes at whatever interval you want. And you can pretty much customize to a much greater extent than you would ever inside sort of Epic per se. Okay. All right, so I'm going to tell you a little bit of story of, like, I'll just tell you about the steps that we took with regard to pediatric diabetes. And so I would say it's like a microsystem. I'll give you a hint of what we're doing in obesity too, but I think this was like a good opportunity for us as a system. So we, participate in the T1D Exchange, which is a national collaborative focused on type 1 diabetes. A lot of us have our sort of parent organizations that sponsor a lot of these collaborative networks, but it's certainly helpful when you're dealing with rare diseases, right? Because we haven't necessarily been deeply embedded with our adult colleagues. So we just have this population of 1,400 kids, which isn't a huge amount of children. And I would say across the country, we've all been sort of grappling with the fact that we've known for 30 years that better glucose control and lower A1C is associated with better outcomes in type 1 diabetes. But our ability to achieve that has been pretty dismal because we're probably at about like 20 or 30% across the board, even at sort of the more specialized centers, the centers with large donors and more resources, right? Like we've all kind of been stuck, right? And I also think that there's in our culture, there's been sort of this focus on artificial pancreas, right? So that affects like a small subset of our kids, but it doesn't affect sort of the broader population, right? So, as a collaborative, we came up with a goal of improving glycemic outcomes, right? And so we came up with the key driver diagram. I don't know if you guys are familiar with this, but I mean, it's basically the conceptual model for sort of the QI world, right? When you're just talking about sort of drivers that you think will lead to your outcome, like partnership between engaged patients and the care team, efficient use of technology and data to support care, right? And then these are kind of particular interventions that you might interact or that might, sort of contribute to those drivers that will hopefully lead to the aim that you're trying to achieve, right? So it starts with like thinking about what's really important, right? And if you told me 5 years ago what's associated with good or bad outcomes in type 1 diabetes, I would have told you Medicaid versus not, race, right? Like our African American and our Hispanic patients don't do as well as our Caucasian patients, and that's pretty much like all I could tell you about differences in health. And I wouldn't say that either of those things are really modifiable by a clinical delivery system, right? And so I think it's like a little bit frustrating, right? So, as a collaborative, we came up with some metrics that were based on the literature, right? This is sort of more recent literature that's come out about, the fact that the more you check every day, right, the lower your A1C. Makes sense, right? But no one was measuring that, right? Or there was an interesting paper that just came out of UCSF that was like, oh, let's just look at people who download their data, right? Because a lot of us have devices now. Now there's platforms where you can download it at home. You don't have to just do it at the clinic office, right? And so they did find these, associations of people who review versus don't review. I'm doing better, right? And then studies have been done looking at research cohorts where they're just looking at really well-controlled versus poorly controlled kids, right? And some of the things that they found included BG frequencies at a certain level, bolusing before meals, not missing insulin doses. So really basic stuff, right? So we as a group, but then like I as a builder, right, created these flow sheets, right? So worked with the HITS people and the ambulatory people to figure out how to get this into the workflow. But now there's like a tab on the left-hand side of our diabetes clinic visits, right, where you can hit pediatric endocrinology, and this comes up, right? And now we have structured data to measure a lot of the metrics that I just talked about, right? And so some of this is long. Oh yeah. So these represent sort of the 6 items. So there's a lot of different items here, and I'm like very attuned to the fact that workflow is an issue, and like clicking a lot of buttons is like having something that's too long can be a problem, because if you have a tool and it's the most perfectly designed tool ever, and if no one ever uses it, it's absolutely useless, right? And so, when we created the forms, we did a lot of stakeholder engagement and with our team, which is really a microsystem, right? But, because we have educators, we have admins, we have clinicians, we have fellows, right? We tried to keep like the most important stuff at the top, right? So we all have this model where like educator goes in first with the patients, and then clinician goes in later. And so we decided to kind of like put that stuff at the top, right? And so clinicians, not always, sometimes they go in by themselves and they're just like not as reliable as the educators, right? But we sort of just tried to yoke all the most important stuff to the top, like those metrics, and then said, do what you can for the rest, right? But I think, it was an interesting process because we had all these questionnaires, right? So we had stuff that was just being entered into the note. And we had all these questionnaires that we were having people fill out on pieces of paper as they came into the clinic. And then it would immediately get PDF, like we would never actually look at it, and we would never actually do anything with those responses, right? So we really culled it down. We did our Marie Kondo for data, right? And it's interesting because there's just like a lot of questions that exist that are historical, and you think that someone else wants it, but in fact, no one wants it, right? So we had to deal with US News and World Report. We had to deal with Nursing Magnet. We had to deal with ADA certification, right? But we were able to cull it down, and we're able to develop questionnaires to allow all of our patients now sort of whole scale to come in and just fill this out as they come into the system, right? And there have been like some hiccups with these tablets. There's a lot of specifications you have to use around like making sure that the responses are as small as possible. Like no one ever told me that your boxes are going to be big as your longest response, right? Or that like a question doesn't even barely fit on the same page, right? So we run into a lot of hiccups, and there's some issues with the scrolling too, because people will miss this and then they'll just hit this and then they'll just skip the question, right? So we've like had to make a lot of the questions just absolutely required and then leave a I don't know answer, right? But it's given us an opportunity to sort of add questions that we think are important for like clinical care and for research, right? So Dana Albright is one of the new faculty members in pediatric psychology. She's exclusively focused on diabetes, right? And so, we were able to get some of these questions in, some patient-reported outcomes that we think are interesting because we want to look at people who have higher self-efficacy, and we want to see what those associations are with A1C, right? And I think what it allows us to do is also do some like subsampling. So you can't take like a 50-question questionnaire and like just dump it into the clinical workflow, right? But if you can get a hint of something, like if there's a lot of diabetes conflict between parent and child, and we know that that's associated with poor outcomes, right? Like Dana can go in, find those patients, do a more comprehensive survey among people who report conflict versus those who don't, right? And it's just sort of a cleaner and more effective way to think about doing research as opposed to just kind of convenient sample in the dark trying to find patients or populations, right? And then all of our structured elements, whether they're flow sheets or questionnaires, that all go straight into our note, right? So there's a smart phrase that we've created, right, that literally takes every element. I use the workflow that we already had, the templates that we already had, and then everything just gets inserted, right? So now instead of doing F2 all the time, which is this horrific thing on Epic where you're picking like from like these terrible drop-down menus, you literally hit the smart phrase, and then your note is done, right? But more importantly, I have metrics on the back end, right? And I think one of the hardest things is that people are used to operating, like the model was like you use the node as your source of communication. So in the old days, that's what you do. You use the node as your source of communication. That was the source of data, right? But now we're moving to a model where like hit the buttons, right? And the node is like the afterthought, right? Yeah, that's just the communication piece, but the real value is in capturing the structured data with meaningful metrics, right? So when you look at, and we still have to publish this data, right? Average A1C for people who do versus don't do behaviors, right? So for example, do you check your blood sugar 4 times a day or wear a CGM? I know it seems kind of crazy because like we prescribe CGMs, but like we couldn't tell from the EHR data and the way the scripts were entered, like who actually was on a CGM, right? Or we couldn't tell, no one ever wrote like checks 4 times a day, right? Based on the meter download, right? So now we have these kind of behaviors, right? That are clearly linked to glycemic outcomes, right? Because people who do the behaviors have at least like a 1 point difference in A1C than those who don't. And then if you add it up, right, if you have someone who does none of the behaviors, or 6 of the behaviors, there's this like beautiful gradient with this huge clinical like significance, like 4 percentage points is enormous, right? And I think the value to us has been that, you know, in asking about some of these things or introducing it to the workflow, not only are we measuring it, but it's leading to conversations with my teenagers about the fact that, oh yeah, I'm still bolusing after. And I'm like, why? Why are you bolusing after? Like I never even thought to ask you because I would have assumed that you just didn't do it, right? But it's allowing us to sort of have meaningful outcomes that are modifiable, that can be addressed through quality improvement interventions, right? That we can sort of use to try and improve the outcomes for our population, right? And so we maintain a newsletter. Jake on our team is sort of the excellent designer for this, right? And so what we're able to do is now translate some of this to like our communications with the families, and we're sort of developing some shared decision-making interventions and sort of QI interventions to be able to transmit this to the larger population, right? So way better than, oh, are you on Medicaid and are you non-white, right? Way more modifiable, way more doable, and I think way more optimistic, right? And so this is just an example of the dashboards that I've made. So for example, just pre-visit planning and having to do labs that meet our US News and World Report metrics, right? Now you can just go to this website. I can share it exclusively with only people in our clinic because it's totally kind of partitioned by permissions, right? And I can figure out, I can find my name, eliminate all my other providers, filter them out, right? And then just have my list of who I need to order labs on. I don't have to do like 12 clicks to figure that out, right? And, you know, we've been doing loss to follow-up in our clinic, and Ashley would spend like oodles of hours like trying to like pull together spreadsheets and, you know, from like crystal reports and stuff like that, but now it just pulls, right? And so the admins are now using this to find the patients that need to be rescheduled because they're overdue, and they're even leaving notes that they can sort of, you know, use for situational awareness between them and the social workers, right? And then I just want to mention that on the research end, because we have some projects related to kind of computing and data from devices, we do have a ton of clinic accounts where we have like the CGM, the U of M clinic, everyone sort of connects their CGM to that clinic account, right? So we have a lot of pump and CGM and meter data. So we're also kind of downloading that in mass to sort of join with the EHR data. And so, you know, I think the point that I'm just trying to make is that we have a lot more opportunity to do interesting work because we fixed the plumbing. Not fun to be in a building that has no bathroom, right? Okay, so design principles, develop a measurable aim and theory of change, understand the stakeholders' workflow and reduce data, right? Create meaningful metrics, reuse data to reduce the work of documentation, right? And then actually start using it for doing really interesting and creative things. That's what I think is really exciting. All right. So I think some of you guys have seen the slide before from like the pediatric research symposium, right? But I think what I want to just make a plug for is that once you start doing learning health system or sort of QI in mass at large for the population, you just have many more opportunities to leverage data, to understand the population, and to do research more effectively, right? And so, whereas before we were doing manual review, now we have automated data extraction of structured elements, right? Before we were doing one-time measurement of isolated outcomes on convenience samples of patients, right? But now we have continuous and real-time measurement for the entire population. We didn't have any patient-reported outcomes, right? But now we do because we have things like the portal and tools like tablets in clinic, right? One of, I think, the interesting things about QI is that, there's a lot of variations in care just due to, just problems in clinic, right? And so you actually have decreased statistical power due to the fact that you have variation in outcomes from inconsistent care delivery, right? So you potentially have the opportunity to increase your statistical power as you kind of clean up the system, right? And then I think, we, as much as possible, really want to bring together, bridge together sort of the clinic and research divide, right? And so I've been working on learning health systems for childhood obesity probably for over like maybe year and a half now. So we convened a meeting, I think, here maybe like last February or something. I can't remember. But I've been working with Kelly Wenger in particular, Karen Peterson, who's the chair of nutrition. I want to acknowledge my team who has been like absolutely instrumental in this, Emily, Ashley, and Val, right? And we're sort of thinking about sort of applying the same kind of model, but like locally, just because obesity is so prevalent. And we think it's an interesting opportunity because it's just a much larger system, right? So we have our key driver diagram focused on reduction of weight, right? We have outcomes that, I think we're still sort of exercising or figuring out what we want to do, but, even just identification, I think, is the first step. And this was actually one of the quality metrics that we validated in 2012 with the Key Metric Project, right? And got uploaded to the, the HRQ data clearinghouse, right? But, that was in 2012, and now we got to get it into action, right? Just to give you some examples of things that we've been doing, so trying to yoke health IT more into sort of the management, right? So I've been convening kind of subspecialists, generalists, and research faculty on the kind of obesity nutrition side from School of Public Health and other places, really, to sort of come up with more just consistent systems, right? Because right now obesity, oh yeah, go ahead.
Sorry, could you go back to that last slide?
Yeah.
What is the gap in terms of full coding among those who actually criteria?
So when we, So when we looked at it, still waiting for my analyst. So when we looked at it, we looked at it at Data Direct using one of our kind of Carly, who was one of our research associates, and I want to say that when she did it, because I guess the question is like, what do you call identification, right? Because if you said like syndrome X, or if you said metabolic syndrome, or if you said BMI percentile, or if you had obesity, like there's a lot of different ways that physicians code, right? Like code overweight, right? Or maybe like complications from overweight. And I actually want to be clear about the fact that I recognize that a lot of physicians won't actually code it because like I've been dinged by like calling someone overweight and then I saw them in endo and I did all these labs and then like the mom got like all these bills for all the labs because they're like, we don't cover any services associated with obesity and overweight. So there's other kind of factors that impact the documentation. So I want to say it was around, do you guys remember? I think it was around like 20 or 30%, but we're going to have to get like an official baseline because we kind of did it using Data Direct and we haven't yet done it with like the official problem list in Epic. So I guess the one thing I wanted to say was that, so there's a difference between problem list and visit diagnosis, right? So whenever we see someone, we're going to put a diagnosis for whatever the primary like code is for what we saw them, right? But I think there is an issue with billing. Like there's a disincentive for pediatricians to use particular codes because it will lead to possible like non-payment, right? But what we're trying to yoke to is actually identification on the problem list. And before I started working with Health IT, I kind of underestimated the importance of this. But for example, we have to have it now in our patients with diabetes, and like Ashley will email me and be like, Joyce, you saw this new patient and there's no diabetes in the problem list. But getting that into the problem list actually links them to the diabetes registry, which allows us to do the population management, which then allows us to have more capacity to do things, right? So to a great extent, we're sort of ignoring visit diagnosis codes, and what we really want is we want the actual diagnosis in the problem list because Epic can use that to then generate registry and population management activities. So, we came up with this kind of multidisciplinary group with some guidelines that we were going to basically call Michigan Medicine Guidelines. So we didn't have, no one like mandated us with the authority to declare this, right? I just kind of worked with Kelly. We got some of the key people in like liver, cardiology, endocrinology, right, to kind of weigh in on this, right? And so the idea is that we want to add diagnoses to the problem list. We actually don't want any terminology like obesity, morbid obesity, any of that, because we know that's going to print out in the after visit summary, and we don't want it to cause, I guess, distress to kids or families. So Kendra Sonneville, she's kind of like, she worries a lot about sort of the negative consequences of weight and eating disorders and things like that, right? Or weight focus and eating disorders, right? So, she kind of helped us come up with this list. And it was really interesting because when we went to population health to get like approved for a BPA, a best practice alert, that would allow, like, once someone gets weighed, then if their BMI percentile comes back positive, then, clinicians get triggered to like choose one of these diagnoses to add. They actually were like, we should use the CMS code because we get paid for that, And we were like, why? Like, okay, so it's going to say, so the CMS codes say like morbid obesity, right? Which is a BMI percentile, 99th percentile. But we were like, why? That's like the stupidest thing. Like, you make no money on children anyway. The fact that you want a CMS code, right, to put that is just dumb, right? So we were able to at least sort of push back on that and said, we only want the percentile codes. We want people to be aware of this, right? But we don't want labeling happening at very young ages, right? So, and then we came up with a smart set and recommendations for screening. And, there's like what the guidelines recommend with like all these different criteria for like, do you have diabetes risk? Does your mom have gestational diabetes? Do you have a first or second degree of history of type 2? And it's just too complicated, So we kind of just simplified it and said, okay, let's do these things like every 2 years, starting at a particular age. Let's just do it across the spectrum. We know it's not perfect. It doesn't exactly match, but I think there's just realities to how you get physicians to do things inside the clinic, right? There's a reality to doing this. You can't just make it perfect every time. We came up with, okay, if these things come back elevated, what's the next step? Because we don't want to leave clinicians in the lurch. Why would you not do a test? Because if you did a test and you didn't know what to do with it, then what are you supposed to do with that, right? And so we're in the process now of actually getting this live and up inside the system. But, now that I'm one of the ACMIOs for pediatric research, like I have the ear of Ramjeet Ayugari, who's our CMIO, right? And, there was an interesting paper that just came out in the New England Journal about learning health systems, right? And it was about NYU and how they tried to do a lot of sort of like study just to understand the impact of some of the things that they were doing at large. But they are doing like randomization because they want to understand what works and what doesn't work, right? Just for sort of QI and for operational purposes. They don't want to waste money on things if they don't work, right? And so we're going to try and do this as a randomization. We're still sort of picking out what our criteria are going to be, and we're just going to basically do it by clinic level, right? So there's 9 primary care clinics in general pediatrics, and there's like 40,000 kids who are getting care from them, right? So we think that's an interesting opportunity, whereas before they would have just, done like ramp up in one clinic and just expand to the whole system. We do want to study outcomes, right? And we do want to study the use of this BPA, and we do want to think about what study designs we can embed in this to help us understand how best to achieve the outcome we're trying to achieve, right? And so I think we're in that process now. And what's interesting about Michigan Medicine is there's one committee that has governance on all the BPAs in the entire health system, and now I'm on the committee. So so I'm like meeting with Sarah to figure out the governance issues, right? Because we have to have, IRB. What's interesting about this article, if you actually look at it, so even though they were doing this under the auspices of QI, they actually did register some of their trials in clinicaltrials.gov, which I thought was kind of interesting. Yeah, because you would think that if you're calling it QI, then you can't call it clinical trial. You wouldn't put it in clinicaltrials.gov, but they do. So I think that's yeah, so I think it's kind of interesting. So I'm looking forward to talking to Sarah about that because there's a lot of nuances to this, right? And so a lot of our activities right now are under sort of this umbrella IRB of we're trying to do learning health for the system, and QI activities, right? And I have that dual role, like in diabetes, I run QI, but then I also do research, right? So we're trying to sort of maximize the opportunity for a synergy between those two things, right? But so more to come. So we've done some stakeholder engagement on adding more nutritional questionnaires to the tablets. And so that has been a little bit of a struggle because they're not tablets in all the clinics yet, but they're coming all by February 2020. Again, like these are not, I want to kind of acknowledge that these are not always research grade, but again, they can kind of give you a window into, so there's a sleep researcher and she really wants to know about sleep, right? And so, we're asking about start time and end time, right, of sleep on an average day, right? And so maybe that's not perfect, but one, that's an interesting question that a clinician could use to actually have a conversation about that with the family, right? So it can be used for QI, but then it also can sort of allow her to substratify and say, hey, I want to study these kids who are at the extremes of sleep, and so she can just sort of sample from those groups instead of just blindly shooting in the dark, right? This is kind of off the edge. So we actually just got funded by Michigan Health Endowment Foundation. Thank you, Emily, Ashley, and Val for all your brilliant efforts with this grant, right? But we're actually trying to think about, we're doing obviously like some work locally among our system, but we think the value is really more in collaboration, right? So we will be doing a needs assessment over the next 2 years just to sort of understand institutional capacity for like doing work on QI, focus on childhood obesity across the state. So we're going to reach out to all the different kind of pediatric centers. We're going to be doing some stakeholder engagement and some design sessions to really sort of set up a set of goals and a KDD that would sort of, be built ground up in a participatory way from individuals across, stakeholders from across, health systems, community members, parents, et cetera. And then we'll be doing some internal kind of interventions in the meantime locally. We had wanted to do something much bigger and broader, but what we found was when we tried to engage with, people who are willing to like engage in conversations, like IHA, for example, they have, I think, like twice as many patients as we do, right, in pediatrics. They just didn't have the capacity yet, right, because they're not an EPIC, and, so I think this was sort of a good intermediate step for us to sort of do the groundwork to figure out how to set up LHS for the state. And then the other piece of this that we're kind of building off of is, so there's a Nutrition, Obesity, and Research Core that's like an NIH-funded grant that has a lot of other services. They have a core for like metabolomics, a core for adipose tissue phenotyping, right? So there's a lot of different varieties, but we are going in, our application's going in now to be a childhood obesity research core. And, we're interested in sort of harvesting data from the EHR, being able to sort of do data queries and cohort identification for investigators interested in childhood overweight and obesity. We're interested in creating dashboards, right, to just give more insights. And I do think that I've been trying to get a lot of so Joe, I'm working with Joe on some stuff, and he has an interesting Tableau dashboard that he's using for his PICU, ARD, it's his ECMO kids. Yeah, it's his ECMO kids, right, to follow kind of outcomes for them using like Tableau dashboards because they want to look at were they seen in pulmonary, were they seen in PM&R and all these other places because they need follow-up. And so I'm really interested in one of the things I really want to do with my health metrics role is sort of get more people even into the use of Tableau because I think it's an interesting tool. There's free courses on campus for this, and you can even just take a simple spreadsheet and upload it, but I think it's a really good way for people who are like less quantitative to engage with their data. And I also think that it helps you see the data in a more, like even if someone has coding ability, like it helps you see kind of visuals really quickly of different, like I want to see that by race, slide it over, slide it back. I want to see it by age. I want to see it by clinic, right? It just gives you this ability to quickly interrogate your data in a much more intuitive and visual way. So I think that's kind of one of the interesting opportunities. And then, there is like this opportunity to use more of the health IT inside the system to do more execution on research. So we are pulling together, we sort of like began the process of pulling together a data repository focused on childhood obesity, but it actually will be like actually all of obesity and diabetes in the health system because we have some support from Diabetes, which is a new diabetes initiative. But I think the idea is like, and then, it's interesting because, Research Data Warehouse now has geographic data And so they'll have a lot of census data based on the addresses inside the system, right? So that can be joined with a lot of the clinical data. And they have short scripts data, but use of that governance for like secondary analysis is still to be determined, right? But there's just a lot of opportunities to do more with, I think, the internal structures of our system. So, this is just an example of, we have 41,000 children kind of in our live cohort. There's over 200,000 in the system that was in 2012. But of those, we were able to find the maternal linkages, right? And so there's 10,855 moms. And if you're a childhood obesity researcher, you actually do care about that linkage, right? Because we know that, maternal diabetes, weight gain, glycemia, like all of those things can contribute to nutrition and obesity, right? So there's just interesting opportunities because I was able to find the linkage. I found the family grouper, which is very exciting, right? So part of, I think, the battle inside the system is really like knowing that the data is there, but being able to have the persistence to figure it out. And if you guys are ever wondering, like, when you're like doing something in Epic and you're filling this thing out, if it's a button, it usually is almost certainly able to be captured. But there's a new service called Data Concierge where you can send a screenshot, you can send a CSN and an MRN, right? You can be like, find this data element for me. And they will go and try and find the right table in Clarity to see if you can get access to it, right? And you still need to have access to it, but at least you know where it is and you can tell people where to find it, right? And then, so this is like number of kids for whom we have 1 year of data, 2 years of data, but we have some kids for whom we have a lot more kind of information about BMI trajectories, which we think is interesting for researchers. Okay, and then the last thing, so Care Companion, this is interesting. It's a little bit under the wire, and I wouldn't say it's like ready for prime time for research yet, but, and that's really purely because of the political issues around HITs and like how they operate, because they pretty much operate for operational purposes only. Like if you went to them and you said, hey, I want to build this, they'll be like, is it for research or clinical, right? And if you say research, they'll be like, oh, sorry, not my domain, not paid for that, right? But Care Companion is like it's sort of this opportunity to create more of an experience with regard to patient questionnaires and delivery of patient education materials, right? And so you can basically set it up to have like to-dos, to show videos or show information to patients, to track adherence, right? To fill out questionnaires at the right time and sequence in the right format. So what's interesting is, so for example, so they've been using this. So this is something that can be built. It's like it can be built. You just got to find someone to build it for you, right? So I'm trying to get the MyChart research team that's sort of funded by MSHR to be able to start doing this or learning more about this so that we can get to this kind of level. But the idea is that, the opioid individuals, right, what they're doing for people who are post-surgical, they've created an app like this that says your day 1 of post-surgery, this is what you need to do. You have day 2 of post-surgery, and so essentially what patients can do is they can answer questionnaires on certain days, they can get relevant information on certain days, right? And then, and so the tool can be kind of used to deliver an intervention as well as collect patient-reported outcomes, going forward. So I think that's a really interesting tool because it's sort of like the closest thing we have to mobile technology that doesn't require hundreds of thousands of dollars, that goes directly into the EHR, that could be like embedded in the workflow of a provider, right? And so I think that's a really interesting and cool tool. All right, so I'm just going to end with this. So this is, these are done by a woman, I can't remember where she's from, maybe Greece. She's a designer, right? And she has this series of objects called The Uncomfortable. But if you're boiling water for pasta, do you want to use this pot? No, right? Or if you're trying to eat your dinner, do you want to use that fork? Right? So I think what I'm trying to make the point that design matters, right? And you can let a system just exist because that's how it randomly happens, right? And it doesn't serve your users, and they're gonna have to like use this part to eat their meal, right? Or you can kind of redesign the system to actually make it work to, increase knowledge, accelerate discovery, and hopefully improve child health, right? So Questions, you guys know where to find me.